Good morning, good afternoon, everyone. It's my pleasure to welcome you to another installment of our today's session will delve into the indication of splenectomy, a topic of great importance. Before we begin, I'd like to remind you some key points. Your microphone will remain muted during the presentation. Please note that this webinar is being recorded and that you can submit your questions via the Q&A chat box at any time. Now it's my great privilege to introduce you Beatrice Gulbis, the moderator of this webinar.
Thank you very much. And it's my pleasure to welcome Professor Maria Domenica Cappellini. I'm very proud to have you on our webinars series. So you're professor in internal medicine and you work in Milan. But I think that for this topic, what is very important is to know that you are part of the working group of red blood cell and iron in EHA. You are also the scientific advisor at the Thalassemia International Federation. You went to many countries to meet many patients and many colleagues in the field, and you've been involved in many clinical trials that has led to a significant improvement of therapeutic approach for the patients who have anemia. So it's very important, and I think that the topic today, splenectomy, is inside all your experience about it. Thank you very much, Maria. Nika.
Thank you very much, Beatrix, for the kind introduction. It's my pleasure to lead this webinar on splenectomy in hematological disorders. I'm going to share my slide. I hope you can see them. Can you? Can you see the slide?
Yes, just to
okay.
In
so
slideshow and
okay.
Okay.
Okay. So
Perfect. Thank
good
you.
evening to everyone. As I said, the subject of this presentation is splenectomy. These are my conflict of interest, and these are the learning objective of this webinar. I just start introducing a bit definition of splenomegaly and causes of splenomegaly, and then I will move to splenectomy indications and consequences of splenectomy. Just, I don't want, of course, to go into the anatomical issue of the spleen, but just to remind you the structure and function and cell population of the spleen. There are three main compartments: the white pulp, the marginal zone, and the red pulp. And in terms of function, the spleen is a lymphoid organ with two main functions. One is hemopoietic, especially during the in utero period, and the other one is the immune function. Currently, the hematological disorders constitute the main indication for splenectomy. Once more, just to remind you how and when we may define a increased volume of the spleen. So there are different, way to define it. Anyway, the normal spleen usually is not palpable in a normal condition. But of course, you may have a progressive increase of the spleen volume, and according to some definition, a splenomegaly is defined as a moderate if the largest dimension is 11-20 centimeter and severe when is greater than 20 centimeter. In more recent definition, massive splenomegaly is also already considered when the spleen is enlarged in terms of craniocaudal length of more than 17 centimeter. The way to evaluate the spleen volume, of course, can be in a physical examination, but of course, with a physical examination, you cannot properly define the volume. So you may use some imaging, starting from abdominal endoscopy, ecography, or MRI. MRI, at the end of the day, is the most reliable way to evaluate the volume of the spleen. The differential diagnosis of splenomegaly is really extensive. Sometimes is quite evident the etiology because of light in family history or the clear pathognomonic and laboratory findings, some lymphoadenopathy, for example, or other particular condition. So in some cases, the presence of a huge spleen have a clear etiology, and the differential diagnosis became quite easy. But although less commonly, but there are situations where the patient present with splenomegaly, and it's very difficult to find out any specific findings associated. No family history, no significant hematological cytopenia with abnormal morphology. So in such cases, the cause of splenomegaly is really challenges and particularly stressful, either for the patient or for the physician. For the patients, because sometimes it complain an abdominal discomfort due to the presence of huge spleen. And of course, the patients want to know the reason of this. And from the other side, the physician, although performing some of the, let's say, laboratory of even imaging testing, cannot have a quick answer. And that's really induce physician to perform invasive tests such as bone marrow aspiration or biopsy, liver biopsy, and sometimes, fortunately, much less now, but in the past, splenectomy was performed for diagnostic purposes. So just 2 slides to tell you that in front of a splenomegaly, a kind of stepwise approach should be considered without being in rush. You have to be in rush only in presence of rupture of the spleen, which sometimes often may occur due to trauma, for example. But excluding this acute situation, actually you have to evaluate carefully any step before moving to splenectomy or even to inappropriate treatment. So first, collect an adequate history and perform an accurate physical exam. Then proceed for a lab test, imaging test, and just rarely you may have the need of histology of the spleen. Keep in mind that, as I mentioned before, there are many causes of splenomegaly, and at least a partial differential diagnosis may include hematological disorders, portal hypertension, storage diseases, which are very often neglected, such as Gaucher disease or ISMD disorder or Fabry disorder, systemic diseases, infection, tropical splenomegaly syndrome, and cryptogenetic syndromes. And as I said, I mean, in some cases, you may have some benign and malignant masses of the spleen found incidentally during imaging, and in such, for example, splenic cysts or benign tumor, and in such case, of course, you may proceed to surgery, and on the surgery you may actually have sorry, or something happened, I don't know what. I have to go back. Can you see? Okay. So
No,
Right.
we have
No?
no problem.
What
So you
happens?
can't go to the next slide or something?
Okay, no,
Okay,
sorry.
okay.
Something was wrong. Okay, so having said that, let's move to splenectomy. Now, that was the stepwise approach, and why the title of my presentation was splenectomy. As I mentioned before, splenectomy in the past was much more common. Fortunately, in these days, with the progress of medical therapy, particularly with the monoclonal antibodies, the indication and the result of splenectomy for hematological disorder have changed enormously in recent years. However, some disorders still and require splenectomy, including some hematological disorder related to red cell membrane hemolytic or platelet disorder. So what are the absolute indication for splenectomy? As I mentioned before, in presence of a splenic trauma, which implies a splenic rupture, you may immediately go through surgery, or in some cases, you may have a spontaneous rupture of the spleen, and again, in such cases, you have to go through splenectomy, or splenic abscess, or in some cases, neoplasm or aneurysm of splenic artery. The relative indication and benefit of splenectomy are listed in this table, and you see that there are different sessions, but we will focus on the number one, including the hematological condition, which are mainly hemolytic or hematological malignancies or myeloproliferative disorder or thrombocytopenic disorders. But you will see that some are more important. You can see that, for example, the indication for splenectomy is much more common on hemolytic disorder than in the others, and is more advisable in thrombocytopenic condition. So I will mainly focus on some of these disorders due to restriction of time. And again, in this probably enlarged table, you see that the main hematological disorder potentially requiring splenectomy are the red cell membrane and hemolytic disorder and the platelet disorders. So I will focus on spherocytosis, thalassemia, sickle cell disease, and platelet disorder. Let's start with spherocytosis. These are the classification based on of spherocytosis based on some criteria, precisely hemoglobin, reticulocytes, and unconjugated bilirubin. And you can see that spherocytosis may be classified in mild, moderate, and severe, and the indication for splenectomy are mainly limited to moderate and severe, whereas the mild form usually don't require splenectomy. This is a relatively recent paper from the Italian group, including a very large number of patients with hereditary spherocytosis. And what is interesting is the change trend of splenectomy, as it is clearly shown in this graph. The patients were subdivided according to the period, different period along 40 years, and you can see that the trend change, splenectomy was 44% before 1990 and dropped to only 7% in 2011, 2020, so in the last decade. And also the age of splenectomy progressively increased. You can see that 73% of splenectomy was performed in children before the 1990, whereas in the last decade the splenectomy was mainly performed in adult patients age over 20. So this is an important observation, proving that there is much more attention before proceeding to splenectomy, even in spherocytosis, which definitely is the most, let's say, most typical condition of hemolytic state requiring the splenomegaly. In fact, the conclusion of this author is that in any case, the effectiveness of a splenectomy of anemia in hereditary spherocytosis is clearly greater than that observed in other hemolytic anemia, for example, in PK deficiency or dyserythropoietic anemia. For this reason, although the trend is dropping down, the suggestion is to evaluate case by case, starting from the intermediate situation, take into account not only the hematological parameters, but also considering the lifestyle, the patient's reported outcome, quality of life, wish to become pregnant. This could be a point to be discussed with the patients for the need of splenectomy. And concomitant cholecystectomy, for example, a patient who is undergoing cholecystectomy, it should be considered also for splenectomy. And these are the guideline published by EHA on hematologica in 2017, and substantially they confirm the recommendation which were present in previous guideline. There are some data also on subtotal splenectomy in spherocytosis, as you can see in this slide. The paper was published in Blood in 1916, but the conclusion is that there is no real differences in performing subtotal splenectomy or full splenectomy. The suggestion is in favor of full splenectomy. So going back again to the recommendation here, other than spherocytosis, you can see also PK deficiency, where the splenectomy is considered only in severe anemic and transfusion-dependent patients. In other congenital non-spherocytic hemolytic anemia, for example, in case of G6PD deficiency, that is really very rare and limited to a specific class of G6PD deficiency. In hereditary stomatocytosis is contraindicated. In CDA type 2 is only considered in case of severe anemia and symptomatic splenomegaly. I will go in more detail for sickle cell and thalassemia. Nevertheless, what I want to underline is that the conclusion for this hemolytic condition is actually to discuss case by case, take into account the patient's outcome and the patient's clinical performance. As for thalassemia, again, I start showing the changing pattern of a splenectomy. In the past, we used to splenectomize transfusion-dependent thalassemia patients usually after the age of 5, and back to the 80s, the majority of thalassemia patients were splenectomized. Here, in this paper, which is already performed 10 years ago, you can see clearly a trend of change in terms of splenectomy. Today, we can say that almost none of the newly diagnosed transfusion-dependent thalassemia patients, or even those who are 20, 25, none of them are splenectomized. And the concern about splenectomy in thalassemia started back to the early 2000s, when we start to realize that splenectomized patients, thalassemia patients, were at high risk of thrombotic event. We didn't care of thrombosis in thalassemia before 2000. Actually was not considered one of the major complications. Then we start to have an increasing population in terms of age, but also we had a huge number of splenectomized patients, and we start to see several repeated thromboembolic events. And this study performed in a large survey of including more than 8,800 patients from Middle East and Italy, we found that almost 4% of non-transfusion dependent thalassemia patients had thrombotic events, and 1% also among those transfusion dependent. And the main risk for this thrombosis were age over 20, previous thrombotic events, family history, but the most important risk factor was splenectomy. And this was confirmed in a study of approximately 600 non-transfusion dependent patients, the optimal care, which is now quite dated, but is still a main stone for understanding the complication in thalassemia. And actually, in this cohort of patients with non-transfusion dependent thalassemia, we identify 3 groups: splenectomized with documented thrombotic event, age and sex match splenectomized without thrombotic event, and age and sex match non-splenectomized. Here you can see the type of thrombosis they had. But what became very clear from this study was that the group 1, those splenectomized with thrombotic events, had significantly higher number of nucleated red cells, platelets, and mostly were irregularly transfused. So we learn that splenectomy actually was a driver of high number of nucleated red cells, high number of platelets, and both contribute to the thrombotic events. And further, there were data on silent cerebral infarction in splenectomized patients. And actually, here you can see again the risk factor. So with this consistent data, the recommendation was to avoid splenectomy as much as possible in thalassemia patients. And of course, there are some pros and cons to consider, because any recommendation should be tailored on the patients, and for sure take into account the risk, but we also may still consider in specific cases the splenectomy when, for example, the spleen is too huge to create abdominal discomfort, or in case of severe cytopenia. Another important observation, these are data just published on British Journal of Hematology, or maybe they are still online, from an Italian study, is a national database. And this is quite important because it underlines that the complication, and in this slide, the complication considered are infections. The reason or the important factor contributing to incidence of complications is mainly the underlying disease. So this database includes a very, very large number of splenectomized patients within the hematological or, let's say, hemoglobinopathies. You can see sickle cell disease, non-transfusion dependent thalassemia patient, and transfusion dependent thalassemia patient. And what Casale reported is that, for example, splenectomized sickle cell disease are more at risk of infection complication than other splenectomized condition, or in terms of vascular complication, the probability risk is similar in any condition. So just to conclude for thalassemia, the conclusion is we try to avoid splenectomy as much as possible, considering the high risk of thrombotic complication. Sickle cell, again, this is a work from the Italian national collaboration. And in sickle cell disease, the conclusion is that splenectomy does not affect survival rate and the incidence of fatal, not just infectious event, in patients with sickle cell disease. And here you can see the survival in sickle cell disease according to genotype and splenectomy, and there are no significant differences. We have to say that splenectomy in sickle cell disease is much less performed already because actually we try to avoid splenectomy in sickle cell disease. It occurs mainly when there is infarction of the spleen, or sickle cell patients may have a spontaneous asplenia, and they goes through the risk of infection as splenectomized patients. Platelet disorders, ITP and TTP. I want to show this slide, which I like very much, and is just appear on Blood Reviews, which is a summary of novel approaches to ITP, and you can see how many pharmacological approaches are now available. So with this armamentario and this scenario, the splenectomy in ITP is carried out at a much lower rate than previously, and is, we may say, probably the late or even really the last option treatment. Again, is down, but is not out. And this is a Blood paper on how I treat ITP. Is not as recent as the last paper, so some of the pharmacological treatment were still not available when this How I Treat was published, but I thought important to mention, because you may have a look at this paper, and I just took some comments. The decision to proceed with a splenectomy in a specific patients depends on characteristic of the ITP, age, general health, lifestyles, and goals. So once again, although it is a different disorder, but you see, as for spherocytosis, for example, that the patient's behavior and patient involvement in the decision is quite important. The other point is that we probably don't have yet long-term outcome comparing splenectomy and or other pharmacological approaches. So we still need to have more data with the new treatment in terms of final evaluation of splenectomy or treatment. Anyway, it's suggested to postpone or to defer splenectomy after the at least 12 months of ITP onset, and try before considering splenectomy any therapy available. There are several situations in which still splenectomy is evaluated. Again, this comes from the blood how I treat, and here are reported the main, let's say, difficult situation. For example, in presence of profound thrombocytopenia, bleeding, or poor or transient response to any novel treatment. And in such cases, splenectomy is generally effective, even if splenectomy does not result in a complete remission, and it may be then associated to the use of pharmacological agents whose efficacy may improve after splenectomy. Another consideration of splenectomy can be evaluated for young patients with an active lifestyle, particularly for those who used to have sports, sport of any high risk activities. In this situation, the trauma or spleen can be a risk, so this should be considered. And here you can see some suggestion on using splenectomy or contraindication to splenectomy in favor of, for example, thrombopag or other compounds used for the treatment. This is a paper, a meta-analysis comparing the efficacy of laparoscopic splenectomy versus open splenectomy for idiopathic thrombocytopenic purpura, and the conclusion is that in terms of overall response, the laparoscopic splenectomy has the same effect than the open splenectomy. The risk of laparoscopic splenectomy are the remaining accessory spleen, and of course the post-operative length of stay with the laparoscopic splenectomy is shorter than an open splenectomy, but at the end of the day, there is no significant advantages. Splenectomy in TTP, again, is not the first line approach, and is just exceptionally considered in TTP when this condition is refractory to previous treatment, and as I said, is really restricted to few cases. Just for being complete, I mentioned that there are also some lymphoid proliferative disorders, such as splenic lymphoma, for example, that can be considered for splenectomy. But once again, this is less and less common and should be evaluated case by case. We mentioned the in general, the complication of splenectomy, infection. We mentioned, of course, thrombotic risk, which apply very, very well to thalassemia, but also to other conditions. But here is a list of other complication, either intraoperative or early postoperative or late postoperative. And you see here bleeding, a complication of infection. But what is important is to consider that some of the complication, mainly infection and thrombotic risk, could occur at any time after splenectomy, even year after. What to do for preventing infection? Of course, there are vaccination and prophylaxis. There are guidelines in this regard, and I have no time, but I don't want even to go into details, but of course, you have to prepare the patients with the prophylaxis before splenectomy, and to keep a maintenance later after splenectomy. So to conclude, splenectomy remain a let's say a choice for patients with hereditary spherocytosis, those with severe spherocytosis, and case by case evaluated for patients with moderate spherocytosis. Sickle cell anemia is not a major approach, could be performed in case of splenic sequestration or rupture, of course, or hypersplenism. We didn't go into autoimmune hemolytic anemia, but there are, of course, some situations where splenectomy is indicated. For thalassemia, we extensively mentioned the risk, so we restrict the splenectomy. In ITP, young patients, sport-minded, or a patient at risk for trauma, and is exceptionally indicated for lymphoproliferative disorder of chronic multiproliferative disorder. And of course, the case-by-case evaluation is extremely important. I thank you for your attention, and I'm ready to take any question.
Thank you very much, Nika. So I don't see any question in the chat, but of course, feel free to add any question in it. I have maybe one question. When we have the patient with hereditary spherocytosis, and it's not a severe case, of course, but the patient asks you for splenectomy or anything to do because of the patient feels uncomfortable with the disease, so it's more a feeling that really something that is objective. How do you manage it? And the next question is also related to it. So what's your experience with the complication after splenectomy for those patients?
It's a good question, thank you, because sometimes patients actually feel uncomfortable with an increased volume of this organ on the abdomen. And what we do is to discuss with the patients, showing the hematological parameters, and if the hematological parameters are not severe, in terms of classification, the effect of the splenomegaly is not causing severe anemia, the hematological picture is mild, I try to convince the patients to go on with the spleen in. Of course, if the patients say, but I am at risk because my job is physically exposing me to risk of rupture and so on, and I cannot tolerate, we can decide together, okay, we can go through splenectomy. But at that point, I explain the consequences. And I didn't mention, in my experience, and also there are papers from the group in Milan, in long term, these patients tend to accumulate iron, to have an iron overload, other than risk of thrombosis, risk of infection, but of course we keep them under control. But they also go through iron overload. So what to do if they want? We go through splenectomy, but then we don't forget the patients. We keep them on regular follow-up. There is one hand. Probably there is a question. Sotterulla.
There is no question in the chat, but I see that we have one raised. Jesus Terula, could you please write your question in the chat?
Cannot be unmute. Maybe she can. No.
Yes, Jesus.
Okay.
Yes.
Okay.
Hello, thank you. Dr. Professor Cappellini, thank you for your excellent presentation. My question is about the splenectomy in hemoglobinopathy H disease.
Okay.
We have noticed that the complications, especially the thrombosis, is more common in these patients after splenectomy. We have a lot of cases with a problem after splenectomy. We have lost 2 patients with severe pulmonary embolism, and I cannot, maybe the explanation is that the patients with beta thalassemia after splenectomy, they continue having blood transfusion, and the hemoglobinopathy H disease not. But we have patients who had splenectomy with hemoglobinopathy H disease, who is in regular blood transfusion, and even with anticoagulation, she is still having new thrombosis. So it's very, I think that it's very dangerous to decide to proceed with splenectomy.
Yeah. Thank you, Sotterulla. This is a very, very interesting question. We know much less for hemoglobin H disease and splenectomy than in beta thalassemia. I had only 2 patients with hemoglobin H disease splenectomized, and I lost 1, and for pulmonary hypertension. Years ago, now I will be much more careful. We are learning something. My explanation or interpretation is that patients with hemoglobin H disease are more hemolytic. They have a hemolytic component higher than beta thalassemia, and they actually develop a huge spleen. I believe that removing the spleen, they still have a lot of hemolysis, and hemolysis is actually a cause of increasing the risk of thrombosis through the nitric oxide pathway free hemoglobin. So I think that as much as we can, we have to avoid splenectomy in hemoglobin A. The problem is that sometimes these patients, at least in my experience, are less regularly followed than beta thalassemia, because for a long time they feel better, they stay in a good shape with 8 grams of hemoglobin, and when they come, they have a very huge spleen, and we don't know what to do. I mean, we hope to have in the coming years some treatment that may contribute to reduce the spleen without splenectomy. But unfortunately, this is the situation. We have to collect the data and try to understand what to do. Yeah. Thank you for raising this question.
Thank you. There is another question. Do you have any experience in splenectomy for patients that are compounds heterozygous for sickles, for HBS and beta thalassemia?
Well, again, there are data in the literature that beta thal sickle have developed splenomegaly more than sickle homozygous. Again, we behave with these patients as for the thalassemia ones, so we try not to splenectomize. So the suggestion, I don't know how many are in the receiving splenectomy, because there are data on splenomegaly but not on splenectomy, but my suggestion is to avoid splenectomy, because I'm expecting that they will be at risk as the thalassemia patients.
Thank you. And another question is related to the use of anticoagulants after splenectomy.
Okay. Well, this is another difficult question, because we are dealing with younger patients in general, or at least younger than the general population. So we keep a patient on anticoagulation forever. It can be a risk, of course, of bleeding. Nevertheless, my attitude and what also we try to explain on the recent thalassemia guideline that I suggest to look at is, if the patients already had a thrombotic episode, even before splenectomy, because that is possible, definitely will be on anticoagulation forever. If not, we treat the patients with anticoagulation for 6 months post-splenectomy, okay, which is almost equal to the recommendation for the general population for a single episode. But again, is the right way to proceed? I don't know, because we actually had thrombotic events in splenectomized patients after years of splenectomy. So it's not really enough to say, okay, this patient is safe because it was anticoagulated for 6 months. Not at all. Of course, there are other situations where it can be advisable. For example, for a lady on hormonal replacement, if they take hormonal replacement, or for you know, patients who have some cardiac involvement due maybe to arrhythmias or other complications which are now appearing in thalassemia patients after the age of 40, even in absence of splenectomy. So in these patients, if they are splenectomized, there is an important reason to anticoagulate them. So it should be decided case by case.
Okay, and then there is a comment by Olga Cairo related to, of course, the hereditary stomatocytosis.
Sorry, I cannot hear.
Yeah, so there is a comment from Olga Cairo about the fact that if you speak about xerocytosis or dehydrated stomatocytosis, is really important to underline that splenectomy is really more than contraindicated.
Yeah, absolutely. We totally agree on that.
Yeah.
And I tell you also that many years ago, I saw a patient who was splenectomized in another hospital because the diagnosis was not well defined, and actually was a disaster after splenectomy. So no doubt.
There is still another question. So the of course
I
you
can read it.
yeah I can read it. Do
He's
you have any
asking of
concern
any
about long-term
concern
with
about long-term treatment with
Mhm.
luspatercept in splenectomized patients.
Mhm.
Based on the available data, my answer is so far I have no concern. No concern. Splenectomy per se is not a contraindication for treating patients with luspatercept. If we want to be precise on the BELIEVE trial, we had, if I remember correctly, 6 cases of thrombosis under luspatercept treatment. And all these cases actually were splenectomized, but I want to underline one more point. They were not only splenectomized, but they already had previous thrombotic events, previous to be treated with luspatercept. So my comment is, if you are going to start treatment of luspatercept, please evaluate the risk of thrombosis in the patients. If the patient already had a thrombotic events in the previous history, even if not splenectomized, you may consider to anticoagulate the patients under luspatercept treatment.
Thank you very much, Mika.
Okay, I think we are
last...
perfectly on time.
It's the last question. So this is only advertising.
Okay, good. So I
This
thank
is
you.
not for you, this is for us.
Thank you,
So
Beatrix.
thank you very much, and hope to see you in
In
EHA.
Milan.
Thanks a lot. Yeah.
Thank you. Bye bye to everyone.
Bye bye.
Thank you,
Bye.
Maria.
Bye.
Bye.